Welcome back to the post-lunch session, and I hope I do not put you to sleep. But even if I do put you to sleep, there are much better speakers who will follow me, who will probably wake you up. So, I've been asked to talk about this old molecule, but which is still a good molecule, and that's metformin. And before I start, I don't have any conflicts of interest, but some of these slides have been provided to me by some of our pharma partners, so those are not my slides. And you may take photographs of this presentation since it does not contain any unpublished data. So what are the learning objectives? We will introduce metformin, talk about its role in the latest guidelines, see what are its cardiovascular and metabolic benefits, some new evidence on its anti-aging, anti-gerontological properties, some evidence which is not really that new but which has been roaming around in the literature about its anti-cancer efficacy, and finally what are the broader implications of these findings. So we all know that metformin is one of the oldest oral anti-diabetic drugs, and probably it's now one of the most widely used agents, notwithstanding the expanded indications of many of the newer agents. It's actually a plant product. It comes from French lilac or Gelliga officinalis. It's otherwise known as goat's rue. And it was first discovered to have anti-diabetic properties way back in the 1920s, but since in the 1920s insulin also was discovered, people are not really interested in any non-insulin therapies at that time. Subsequently, in the 1950s, a French group led by Professor Ron Stern re-identified the benefits of this category of molecules called the biguanides. There were two molecules in that category, metformin and fenformin. There was a third molecule called buformin, which never got much popularity. And these were used widely in Europe, India, and fenformin was also used in the United States. Unfortunately, due to risk of lactic acidosis, fenformin was withdrawn, and metformin got tarred with the same brush. Belong to the same family, so families tend to have common characteristics. So metformin fell into disrepute. Not in India. We continued to use metformin all these years. And it was not until 1995 that metformin got back into the US market. And now it's the most widely used OAD. What's the mechanism of action of metformin? We really don't know. After 70 years, we still don't know. These are all the theories. I'm not going to detail. Suffice to say that if there are more than two theories on how something works, it probably indicates that we really don't know what is going on. But what metformin seems to do is that it seems to trick the cell into believing that the organism is energy replete. And with the organism is energy replete, there is no need of the liver to put out any more glucose. So hepatic glucose output gets shut off. And these are all the mechanisms by which it achieves that target. Mainly, it activates the AMP kinase, which is known as the fuel sensor of the cell, and which inhibits all these enzymes which are listed here, which are key enzymes in gluconeogenesis. So gluconeogenesis gets turned off and hepatic glucose output comes down. So many other theories are there, including a theory which implicates the gut microbiota as the site of action of metformin, but I won't go into those details. And this is the diagrammatic representation of that. And net result is that metformin mainly works in the liver, reduces gluconeogenesis, reduces glycogen breakdown. Therefore, hepatic glucose output is brought down. It also has effect in the intestine, in the muscle, and in the adipose tissue. But these are all minor effects compared to what it does to the liver. So the main site of action of metformin is in the liver. Now, what's the current status of metformin as far as the guidelines? This is the ADA guideline. You would have seen it several times already. You will see it more times. But what I would like to point out here is that we are spending so much of time on this side of the guidelines. People who have compelling indications, ASCVD, CKD, heart failure. And we talk about GLP-1 RAs, which we talk about SGLT2, dual agonist. In the case of NAFLD, we talk about pioglitazone and tirzepatide and so on and so forth. I'm not arguing that they are not good drugs, but actually how many people with newly diagnosed type 2 diabetes will have these compelling indications? And this is a slide which I took from the last ADA which just got over. And this is data from the US. And what this data shows is that only around 20 to 25% of individuals with type 2 diabetes in the US aged above 20 years have any of these compelling indications. So why don't we focus more on this part of the slide, which applies to 80% of the population, rather than spending all our time on the left part of the slide, which applies only to 20% of the population. And that is where metformin comes in. Not only metformin, sulfonylurea, DPP-4, AGI, all the old drugs come here. So what do the guidelines say? What are the indications for metformin? First and foremost, you can use it for preventing diabetes in those with high-risk prediabetes. And what is high-risk prediabetes? People with both impaired fasting glucose and impaired glucose tolerance, very high BMI, higher HbA1c, these and people with prior GDM. These are the categories as per the DPP who responded best to metformin for diabetes prevention. The second group, in the general janta, especially in people in whom cost is an issue, you can give metformin as one of the first line therapy or as one of the add-on therapies in combination with the other older anti-diabetic agents. Even in people with stable heart failure, you can continue metformin. Of course, not an unstable. It may not have any benefits, but it's not harmful as long as you give it in stable cardiac failure, provided your renal function is normal. Newly diagnosed, incidentally diagnosed diabetes, HbA1c less than 8.5, it is the initial pharmacological treatment. It is useful in women with features of hyperandrogenism and polycystic ovarian syndrome. And individuals with history of GDM, especially if they are overweight or obese, metformin can be given to prevent the development of type 2 diabetes. And one situation where metformin remains a drug of choice, at least as of now, is in type 2 diabetes in children and adolescents. And now SGLT2 inhibitors and certain GLP-1 receptor agonists have also been approved for the treatment of youth onset type 2 diabetes. But until recently, only insulin and metformin were allowed for the treatment. And as such, metformin remains the first agent of choice while treating young onset type 2 diabetes. In prevention, I don't have to describe it any further. We have the landmark diabetes prevention program and its follow-up, the DPOS. We also have a study from India, Indian DPP, and the DCLIP study, the Chinese trial and a Canadian CANO trial, all of which have shown that metformin can prevent progression of pre-diabetes to type 2 diabetes. Of course, the question then arises when you are trying to give metformin to prevent diabetes, are we just preventing diabetes or treating diabetes early? Because like Professor John Yudkin said, he said it's like giving metformin to prevent a condition for which metformin is the first line of treatment. So that's a matter of semantics. You can argue about till the counts comes home. Type 1 diabetes, we have limited number of trials. We had a session pre-lunch wherein we were talking about double diabetes where type 1 was associated with obesity. In such situations, we can try metformin. It has an insulin sparing effect. Effect on A1C was not that great. There was some weight loss. There was some improvement in the lipids, but there was an increase in reported hypoglycemia. So it's not to be given for everyone with type 1 diabetes. Pregnancy, again, very controversial. Certain guidelines do recommend metformin as the first line agent in diabetes in pregnancy, especially the UK guidelines. There are so many trials which have looked at metformin in GDM, that's a MIG and MIG-TOFU study. Pre-existing type 2, that is the MIGHTY and MIGHTY kids, and both, that is a MOMPOD study. All of them have shown that metformin works. Maybe not to the same extent as insulin. Most people who are on metformin also needed insulin to control diabetes as the pregnancy went on. But there were no immediate adverse outcomes except that women who were randomized to metformin tended to have a higher incidence of small for gestational age. Put it another way, they had a lower incidence of large for gestational age. And these kids, when they grew, when they reached 2-3 years of age, they were also found to have increased adiposity. But these differences did not persist until adolescence. Now, we really do not know the implications of somebody who is born small, becomes fat or adipose, and then reverts to normal. What's going to happen to that individual's long-term risk of metabolic disease? We still do not know. It's not yet time. We'll have to follow them up further. So, as of now, the ADA does not recommend metformin as a first-line treatment either in diabetes complicating pregnancy or in GDM. If you are using metformin for polycystic ovarian syndrome, you can continue it till the end of the first trimester, and that's what the ADA guidelines say. What about cardiometabolic protection? Being an old drug, we do not have any cardiovascular outcome trials with metformin, but we do have evidence from large randomized trials and some observational studies that it may have some benefit on cardiovascular outcomes. Of course, among the randomized trials, the most prominent one is UKPDS, but the issue with UKPDS is that there were not too many people on metformin. The main two arms were conventional treatment or insulin and sulfonylurea. Only a small subset of people who are overweight or obese were randomized to metformin. And in those people, metformin use was actually associated with significant decrease in macrovascular disease, even at the end of the initial phase of the study. which was not the case for the trial as a whole. That is why they had to do the UKPDS follow-up study, where we found the legacy effect and so on. And it's not surprising that metformin does protect the cardiovascular system because of all these mechanisms. Mechanisms on the heart, mechanisms on the endothelium, mechanisms on hemostasis, and mechanisms on immunity, both of which reduce the risk of atherosclerosis and thrombosis. Continuing on from that, it also has beneficial effects on body weight and LDL. This is a meta-analysis published a few years ago, which shows a clear decrease in body weight and small decrease in LDL cholesterol levels. Now, this is very interesting. Now, metformin has been shown in small studies to improve longevity. This is what is known as a gerontoprotective effect. And in this study, they have looked at the effect of metformin in reducing aging in various organs. And most impressively, they find that it reduces aging in the brain, particularly the frontal lobe, by 6.1 years. And this may have some implications in the prevention and management of dementia, which, as you will hear in one of the orations, is one of the major risks of long-standing type 2 diabetes. And mechanisms, again, I don't have to go into the details. Too many mechanisms, that means nobody knows what is going on. But trials have been decided. This particular trial has been, result have been published. A small trial only in 14 individuals who didn't have diabetes but had IGT, 1,700 milligram of metformin per day for a period of 6 weeks. And they found that metformin modulated the aging pathways. It upregulated the genes responsible for DNA repair, DNA ligase and all those things. And it mimicked the changes which are found in model organisms which are shown to extend lifespan. So it is an indirect evidence. It's a small study, it is only hypothesis generating, but other trials are also in process, including the TAME trial, which has looked at 3,000 individuals without diabetes, but age 65 to 80, and looking at whether metformin can prevent development of new age-related chronic disease, whether it can cause functional improvements, improve biomarkers of aging, and it may establish metformin as a tool to target aging itself, over and above effects on cardiometabolic and diabetes parameters. These are some of the other trials which are ongoing. Now, cancer. Now, this was a big issue. There's a big noise, maybe around 7, 8. I recall in RSSDA Hyderabad, I don't remember, I think it was in 2015 or 16. I actually presented a talk on cancer effects of metformin. And that time it was considered to be a very promising approach, but subsequent findings have probably thrown a bit of cold water on that approach. Still, there is some evidence that it may help in the adjuvant therapy of cancer. And it has got effects on cellular proliferation. Of course, hyperinsulinemia per se is, let us say, pro-malignant, because insulin is a growth factor, and the insulin resistance that is caused by, that is characteristic of diabetes associated with hyperinsulinemia, which probably metformin cuts down by various cellular mechanisms. And even the CAMP, the AMPK, which I told you is a target of action of metformin, seems to have some downstream effects which can inhibit cellular proliferation. So these are the mechanisms that have been postulated. And this was a meta-analysis looking at the incidence of all types of cancer on the left side and the mortality in metformin users versus those who were not taking metformin. And you can see on the left, use of metformin was associated with 31% reduced incidence of all cancers. Mortality was reduced by 34%, and this is a big meta-analysis, 47 studies with 65,540 incident cases of cancer. But when we try to divide that or subgroup that among various types of cancer, you are not able to find any consistent reduction over any specific type of cancer. So maybe raising the possibility that it is just a statistical artifact. It has to be driven by some form of cancer, isn't it? No. So in no specific form of cancer was metformin found to be protective. So by itself, it may not have much of an anti-malignant or anti-cancer effect. But what has now attracted attention is the use of metformin as an adjuvant to the existing chemo or radiotherapy. Will giving metformin to these patients accelerate the delivery of these treatments to the target tissues? And once you do that, you may be able to get by with a lower dose of chemotherapy and radiotherapy, thereby reducing the side effects. So that's what we mean by metformin having adjuvant effects. So, and this approach could lead to more safer and more pleasant cancer treatments for patients in the future. Now, of course, we have polycystic ovarian syndrome. We all know what is the pathophysiology of polycystic ovarian syndrome. It's basically a part of the metabolic syndrome. There is overweight, obesity, insulin resistance, hyperinsulinemia, which probably throws the hypothalamo-pituitary-ovarian axis out of kilter. And as such, since hyperinsulinism is central to the pathophysiology of polycystic ovarian disease, it is not surprising that metformin improves ovarian function. And it does so basically by reducing hyperinsulinemia and reducing the hyperandrogenism. It also has some effect in resetting the LH-FSH ratio and the hypothalamo-pituitary-ovarian axis. But around 10 years ago, all the endocrine societies have changed the guidelines such that metformin is no longer the first-line treatment for any of the manifestations of polycystic ovarian syndrome. You have irregular periods with amenorrhea, infertility, and hirsutism or hyperandrogenism. These are the three cardinal features of PCOS. For none of these, metformin is recommended as a first-line treatment. Then when do we use it? We use it if a woman with PCOS has evidence of impaired glucose homeostasis. Either if they have diabetes or if they have impaired glucose tolerance or impaired fasting glucose, that is when we need to consider using metformin in PCOS. It is no longer a treatment for anovulation or hypovulation or hirsutism or infertility. We heard about MASLD MASH quite a lot. Metformin has now been relegated to the background. If you recall the slide I showed you in the morning about the ADA guidelines, you don't see metformin anywhere in the picture. And that's because even though it was shown in earlier studies to reduce NAFLD progression, reduce malignant transformation of NSH, and reduce adverse outcomes in people who had HCC, this has not been borne out by many of the future subsequent meta-analysis. And what we found here is that metformin will improve the histobiochemical profile. That means your liver enzymes may improve. But as I told you in the morning, liver enzymes are no longer considered as a prerequisite for somebody having MASLD or MASH. It's only used to calculate the FIB4 score. It doesn't have any other prognostic significance. So it improves the biochemical profile. You can be happy, patient can be happy, ALT, AST comes down. But if you look at the histology, if you take a liver biopsy and see, you will find that there is not much of improvement in the histology, which is not the case for some of the newer agents like GLP-1 receptor agonist or dual agonist or even resmetirom. So finally, what about inflammation? So at the end of every talk, we have to talk about inflammation, isn't it? But it does seem to have an anti-inflammatory effect as well. Again, the mechanism is via the activation of AMP kinase. And what that does is that it reduces the oxidative stress. Overall metabolism slows down. And when you have increased metabolism of fewer substrates, that's when you get production of reactive oxygen species and oxidative stress, isn't it? So when you shut that down by tricking the body into believing that there is enough energy going around, you are able to reduce the oxidative stress. And it all does that by suppressing key inflammatory pathways like NF-kappa B, NLRP3 inflammasome, and reducing the production of various pro-inflammatory cytokines, IL-1 beta and interleukin 18. So that's how metformin helps you in anti-inflammatory effect. But let's leave all that aside. Even if none of these benefits were there, I think the most important take-home message from this is a drug which we can give with a clear conscience. It may not have any benefits on CVD, it may not have any benefits on kidney, it may not have any benefits on NASH, but we know it's safe. We have been using it for the last 70 years. It's not going to spring any surprises on us in the next 5 to 10 years. And it's inexpensive. Most people can tolerate it, especially at lower dose, and we give sustained release preparation. So I still believe that metformin should be the cornerstone of treatment of type 2 diabetes in most of our patients, if not all. There are expanded roles: cardiovascular protection, weight management, LDL reduction, even in BP reduction, all minimal effects. I don't think you should be giving metformin just for those effects. Anti-aging is something which we are looking for, and if we can find a role for metformin in dementia, that will be a great thing because India is now home to an aging population, and dementia, disability, and frailty are big issues. We'll be having a full oration on that later on. It also seems to have an effect on reducing proliferation of malignant cells, maybe not by itself, but when used as adjuvant, it may be able to help you reduce the dose of chemo and radiotherapy. It also has therapeutic benefit in PCOS, to some extent in MASLD, MASH, and inflammation. Therefore, it is a versatile drug. It is a safe drug, it is an inexpensive drug, it is a versatile drug, and I still feel that it should probably not be at the right end of the ADA guidelines. It is probably somewhere in the center, like it used to be 3 years ago before all this came. I thank you for your attention.